Welcome, everybody. I'm delighted to be here. I know Mary is as well. Let me say a little bit about the motivational training program, which began in September of 2021, just began. It's geared to training people in motivational interviewing in the community, integrating MI into service delivery, improve level of practice. We have a lot of goals, but mostly it's leadership and development and organizational and also clinical skills in motivational interviewing in community agencies. Before that, I was in charge of the MI lab program, which was training all incoming students in a 7-week intensive session of motivational interviewing skills. And out of that, we developed the lab, or the integration of the agency offering programs to communities and agencies. You're probably wondering why, a little bit throughout the background, why 2 social workers are involved in motivational interviewing and medical management. What's that got to do with social work and so on? And my history has been that I've done a lot of medication trials and worked with many different companies and had federal grants. I'll talk about that tonight. But the problem was in medical management, they didn't know how to keep people engaged or adhere to the program. And they had problems in recruitment people, particularly of diverse populations. So I've had some experience in both adherence and in dealing with diversity in recruitment. And so they asked me to participate in many of these trials. And I've done many of them over the last years. Before that, I was in Milwaukee and I did a lot of medication trials. Some of you may have heard about combined study, which is a landmark study in the area. And I'll talk about tonight about the advanced study. The advanced study, Mary was one of my, was a coordinator of that study, and she worked with me in developing this motivational medication adherence questionnaire, using that in the trial itself. So we'll talk more about that tonight, but right now I want to get started. And so I look forward to seeing you later and talking to you more. Mary, are you ready? All right.
I am ready. Thank you, Alan, and thank you for the introduction. Good evening, everybody. We're going to get started with a presentation. I will advise first that I am on the 11th floor of the Columbia building, and I've alerted people on this floor that I'm doing a presentation, but there may be 1 or 2 people coming by. I hope not, but just giving you a heads up about that. All right. So today's presentation, as Alan has spoken to, is about motivational interviewing and medication management. Old problem, new solutions. So before I begin, I'm just going to briefly review what the learning objectives of this webinar is. By attending this presentation, you'll have a better understanding of the role and function of MI, motivational interviewing, in the issues of medication adherence. You'll understand the effective use of MI strategies in addressing medication non-adherence. And you'll also be able to identify tools and measures to help address the issues around medication adherence and medication non-adherence just as well. So in our title, we reference the old problem, right? We say this is an old problem, what's going on in medication management? And the old problem that we're referring to is medication non-adherence. It is a well-recognized, pervasive, widespread problem that's been undetected and untreated for many years, and it's a growing issue. And what are the implications of medication non-adherence? Why is it such an issue? Well, it's very common. 30 to 50% of US adults, we're going to be strictly speaking US here, do not take their medication as prescribed. When we witness non-adherence, it accounts for 125,000 deaths. 10% of hospitalizations in the US are due to medication non-adherence. It is also quite costly, quite a burden on the healthcare system. And in the US, an estimated $100 billion is spent on the healthcare services as a direct result of medication non-adherence. So overall, we can see that this is causing both individual, systemic problems in the healthcare field. And as Alan said, it goes beyond just sort of the patient and doctor relationship. You know, it doesn't mean the implication is involving social workers and other helping professions. So I know this may be a review for some, but I'm just going to go over some definitions here. So what do we mean by adherent and not adherent? So adherent is the extent to which the person follows through on the agreed upon recommendations for prescribing treatments, and more straightforward, taking the medication as prescribed. Adherence is actually not really defined as taking 100% fully your medication. It is around 80% of taking at least 80% of the medication as prescribed. What do we mean by non-adherent? Non-adherent can occur at any stage during a medication treatment. It could be flat out not taking the medication at all from the very start, not refilling the prescription at a pharmacy, taking incorrect dosages, so taking medication at the wrong time of day or the incorrect amount. Very common, we'll be touching on this issue later in the webinar, is discontinuing when you experience a change in symptoms, whether you're feeling better, discontinuing the medication, or if you're feeling worse, and then discontinuing the medication without the consultation of the provider. So there's a reason why we're using this word, this term adherence and not compliance. And the reason is compliance has a different connotation. It implies a different form of relationship, one of where sort of authoritative figure and someone who's more of subservient, who's following orders, that you must be compliant. It's associated with these concepts of being resistant or being in denial that are found to be very unhelpful in the overall treatment process and engagement. A lack of compliance can be seen as more of a personal deficit, a character flaw of the person, that is sort of a mutable characteristic that is unable to be resolved, unable to be changed. So we're moving away from that sort of framework of compliance and moving towards adherence, which provides a more neutral tone that aligns with the larger ethos we're going to talk about here, which is like a shared decision-making process. So how are we going to address this problem of medication adherence? So as we've seen, it's costly, it's risky to the individual with morbidity and mortality, and it's quite common. So how are we going to approach this issue? So the way we're looking at it is looking at non-adherence as the underlying cause may be related to poor communication or understanding of the treatment between the treatment seeker and the treatment provider. We're coming from a place, from the belief that the individual's decision and behaviors are determined by the larger interaction with the healthcare provider and system. So motivation, where does motivation have a role in this? Motivation has been shown to play a big role when addressing adherence issues. And similar to how we view adherence, right, as opposed to compliance, we're looking at adherence, motivation is in a similar way. We are seeing it not less as a trait and more as a state. If motivation were to be viewed as a trait, it would be something that wouldn't be able to change. It's part of your character, it's part of who you are. It's not open to change. But instead, we're now viewing motivation as a state. It fluctuates, it's susceptible to change. It's context dependent, so depending on the time of day, the setting, the relationship, it's amendable. So how do we sort of combine the idea of this motivation as a state and adherence? And this is sort of an idea of the framework we're looking at, and then Alan's going to go into more detail. So it's sort of two prongs here. There's problem acceptance. So that's sort of looking at problem acceptance would be misperceptions, misunderstandings, or uncertainties about the significance of the problem, fears about unintended, and doubts whether about change is possible. Treatment acceptance is different. So there's a problem acceptance. Treatment acceptance would be uncertainty or ambivalence about the whole treatment process, whether the treatment is working for the person. Perhaps there's a miscommunication about the treatment needs, or they've had a history of negative treatment experiences, cultural specific differences. There's obviously a lot of barriers that can occur with treatment. Individuals with high levels of problem or treatment acceptance are susceptible to experiencing adherence issues. Another way to look at this, when one is ready to accept the problem, so let's say problem acceptance, and one is ready to accept the problem but not the solution, we consider this to be ambivalence. And ambivalence is defined as having two competing thoughts in your head at the same time. So two different arguments, two different sides to the same argument. So what that looked like is, on one hand, I know this medication is important for my health. On the other hand, I can't handle the side effects. So again, two different arguments about the same idea here. I know I should take the medication, it's important, but there's these other issues that are preventing me from taking the medication. So when we're thinking about ambivalence, in the past, individuals were labeled as unmotivated, hard to reach, resistant, which again results in poor treatment outcomes, is not effective towards the whole treatment process and treatment engagement. So instead, we're approaching the dynamics of ambivalence through a person-centered, collaborative form of guided dialogue to facilitate and enhance the person's state of motivation, essentially motivational interviewing. We are empowering the individual by eliciting what is important, that's treatment acceptance, and elevating confidence, problem acceptance in the person. So as some of you are familiar with motivational interviewing, comprised of principles, processes, and technical skills that we seek to evoke and reinforce a person's own commitment and motivation for change. How you interact and engage with the person plays a significant role in the person talking about change and eventually actualizing that behavior change, so actually seeing that behavior change. And I'm just going to briefly review some data and literature that exists already on the use of MI in medication adherence. So there have been two systematic reviews, both 2016. The first one here, 19 randomized controlled trials comparing MI alone as an intervention or MI in combination with other therapies as an intervention for medication adherence versus usual care. And in this particular study, this systemic review, majority of the population were new or current users of medication for chronic long-term diseases who self-managed their medication. So the results did prove that MI had a positive effect. The individual MI intervention characteristics, it was a small effect size. MI was found to be statistically significant when the intervention arm was MI by itself. It was performed by trained professionals and with face-to-face delivery. So the authors hypothesized with MI performing well on its own is perhaps when MI was in combination with other therapies, it might have interfered with, it might have introduced some MI inconsistent behaviors that defeated the purpose of the MI. Training is sort of a hallmark of MI, the idea that the coaching and monitoring and feedback of the interventionist and their skills had a positive effect on the effect of MI on adherence. And then finally, those that engaged in face-to-face intervention, so those who were in person, were found to be more effective. So overall, while the effect size was small, MI intervention was associated positively with populations who are taking prescription medication for long-term chronic diseases. In the second systemic review, it was similar. The only difference here is they compared MI alone, so without MI in combination with any other therapeutic interventions. So it was MI versus one or more just pure control groups, and measured self-reported and objective medication adherence in populations, again, taking prescription drugs for long-term chronic diseases. MI showed a moderate efficacy with relative risk of better adherence in MI when compared to the control groups. The mean standardized difference, 0.70, was in favor of motivational interviewing. The characteristics, intervention characteristics where MI was statistically significant, interestingly enough, were phone-based and group delivery mode. Among studies that used fidelity assessment tools, so similar to the last one, the idea of coaching and monitoring, doing quality assurance on the MI skills proved effective. And then the actual interventionist background, nurses and RAs, research assistants, showed a significantly improvement when using MI. There were high variability in types of adherence measures used across these studies, which required further stratification of the sample. So there's a lot of heterogeneity in the effect size. Overall, the results showed a feasibility in implementing MI. Again, both sort of picture the face-to-face delivery, the group-based and the phone-based. The idea that the nurse and RAs had dependent on the receive the training, showing that there's some feasibility in MI training and being able to help, that there was no correlation with education level. And again, it sort of emphasizes the importance of having fidelity measures as well, being able to provide coaching and feedback and the quality assurance and the MI skills. So overall, these conclusions from these reviews, the challenge was establishing determinants for medication adherence. There's a high variability in how people choose to define medication adherence, how it's measured, whether objectively. So a common way of objectively measuring adherence would be counting pills, so subtracting the amount of pills taken from the total amount given. There's CAP systems. A subjective way of measuring adherence would be simply a self-report, asking the person, did they take medication? There's challenges in those measures. There's variability in the mode of delivery, whether phone-based or face-to-face. However, in targeting improved medication adherence, significant and promising effect sizes have been demonstrated with the MI-based intervention approaches in these studies. So with a person-centered collaboration style, along with the added dimensions of coaching and monitoring for interventionists, it is feasible and worthwhile to use MI to promote medication adherence. And this is particularly seen in populations with chronic disease treatment and management. So having said all that, where do we go from here? So where we're going with this webinar is we're going to take this one step further, and we're considering, well, we have this data that shows the MI is effective. What about more intervention strategies that we can use to forestall the adherence? So we're sort of getting ahead of the problem, preemptively addressing the adherence problems, and at the same time aligning with the goals of MI, with shared decision-making, enhancing motivation and commitment. We can increase those when it comes to the medication regimen. And now I'm going to hand it over to Alan.
Thank you, Mary. So I'm going to give you a little background on the approach we're using. I'll be spending some time talking about the details. And then at the end, we're going to do the risky venture of doing a live interview. Mary and I will role play something, but basically it's live. It's not taped, and we're going to show you how this process actually works. But in the meantime, I'm going to talk about what it is and how we developed this model and where it came from, which I found very useful, and have talked about it and published on it and described it in various other publications. So this model we're working on, has developed based on an NIAAA funded study that we concluded in 2018, where we were studying the impact of Chantix or Varenicline on smoking and drinking in a population. And Varenicline was considered very effective in mitigating the rewards of nicotine and alcohol. And both alcohol and smoking were investigated. And in this study, we had 131 patients. I'll tell you a little bit about the patients we had. And the big basic question is, can treatment using varenicline tartrate and medical management reduce heavy drinking and increase smoking, abstinence, and individuals with alcohol use disorder and comorbid cigarette smoking? I'm not particularly going to focus on the findings. We've done that elsewhere, but I want to focus on what we did to help people take this medication and benefit from the intervention, because without taking the medication, it usually doesn't work. People have to take the intervention in order to benefit from it. So medication compliance or adherence, as Mary has mentioned, was a very important component in this study. And this was my area. I was a PI in New York, and the study was done in Yale and Columbia. So there were two sites. Of our population, these are the people we're treating. 29%, 29.8% were women, 70% were men. The mean age was 42 years, and approximately 52.7% were Black. And participants met alcohol dependence criteria, reported heavy drinking 2 or more times a week, and smoked 5 or more cigarettes. This is a heavy drinking, smoking population, and they're very, very hard to treat. Previous research has been very difficult with this population to treat both smoking and alcohol. We can go into the details, but that's not the purpose of this presentation today. It's basically how we help people take that medication and how they benefited. In this particular study, VeriClean with medical management resulted in decreased heavy drinking among men and decreased smoking abstinence in overall sample. The major findings have been published in one of the AMA journals, Psychiatry, and it's been promoted in various other networks like conferences and so on. So there is a major study on this that's been published. But the interesting part is, what about the intervention for adherence? Because that was a big issue. People who are smoking and drinking are hard to keep in treatment, and for that matter, even hard to take the medication. And so that was the major thrust of the intervention, is how do you keep people engaged in that process? We had a manual initially, it was called the Medication Management Manual. It was developed in the combined study, which I was one of the investigators. And in this study, they began talking about using some feedback, design a plan to take the medication, simple reminders, monitoring with pill counts, positive reinforcement, adherence and problem solving, and motivational principles were incorporated. This is what's called motivational interviewing light. We took some of the basic concepts, but a lot of it grew out of a more of a psychoeducational model of educating people using typical reminders, and calendars and so on, with some motivation, which basically boiled down to, you can't persuade people, you can't force people, you have to let people figure out themselves what they want to do. But that's about it. It wasn't very complex motivational principles with complex reflection, double-sided, amplified reflections, and evoking change talk. We did none of that in that study here. Basically, it was a motivational kind of generic approach. MI principles and practices, MI spirit was incorporated in that. But basically, the people who did this were not MI trained. They had an add-on MI approach. It was sort of what they did. We figured in this study here that maybe if we improve, what could we improve on the medication management? What was the way we could do something? And one of the ways we thought about was a new measure called the Medication Management Questionnaire, the MAQ, which was shown to show as a good predictor of adherence. And so the MAQ was looked at as somehow we might incorporate it in basic assessment and to use it as an intervention tool. So MAQ, and I'll say more about that in 2 seconds, provides information on past medication adherence. And based on the responses, we employed strategies to address their issues. You'll see what they are in a second. It was used before as a predictor of non-adherence, but has never been used in the context of behavior intervention to address medication non-adherence. And MI has had its preponderant, its evidence is supported, but as Mary mentioned, the effect size is kind of small. So we really haven't had we've had an impact on it, but not a profound impact. And I'll say a little bit more about that as we talk about it. Okay, so what is the Medication Adherence Questionnaire? It's a 4-item self-report questionnaire to identify 2 distinct patterns of non-adherence. These 2 distinct patterns are forgetful or careless. And so we asked the patients, do you ever take your medication, forget to take your medications? Are you careless at times by taking your medication? Well, the other question was, when you feel better, do you stop taking the medication? So are you intentionally not going to take it? Or if you feel worse, you're not going to take it. These are they're simple questions, but I think they've had some profound impact on what we're doing. So we had this questionnaire, and we developed it as an intervention tool, unlike any other research that have been done. And they basically looked at it as a predictor and not as an intervention tool. Okay, so a person to respond no on all items on the MAQ, and that was considered a low-risk patient. So patients were categorized when they first entered the study. A patient that responded yes to 2 of the items, that means either unintentional, careless, or forgetful, would consider to be unintentional non-adherence are considered moderate to risk. And a patient that respond yes to either of those two items, which is unwillingness, or I might go back to the other one, feeling better or feeling worse, either one of those items was considered moderate risk. So the first one was unintentional, was careless and forgetful, and the second part with intentional had to do with their going back to feeling better or feeling worse. So those are the four items: carefulness, forgetful, carelessness, and unintentional would be for purposeful, not wanting to do it, or put it both ways, feeling better or feeling worse. So those are the four items we dealt with. Okay. So we used other things we did was we focused on greater benefits of adherence rather than the risks of adherence. Because most of the issues are an MI well dealt with its risks, what the risks are. And we felt that really people, if you talk about risks too much, it does increase ambivalence. So we focused mainly on the benefits. So all the case scenarios in the manual were geared to what benefits were and not risks, focusing on what could you gain from it, which it goes into what we call evoking change talk. And so that was, we focused on that in terms of some of the intervention tools. The third thing we focused on was helping people, the counselors or the practitioners, to be more aware of the importance of medication. So having those two instruments or having the information made people much more consciousness of how people were doing in terms of either forgetful or careless, or they were not ready to address it because they felt better or they felt worse. And this is very new because people feel better, you think they're going to keep taking the medication. But often feeling better means I really don't need it anymore. I don't want to be dependent on it. And if they feel worse, they certainly will not want to take it. But sometimes the worse is really more existential in terms of, I don't like the feeling of being in the study. I don't like having to be involved in medication. So it's not as always clear as that really side effects. Okay. And so the question about the feeling better and worse is very much an existential question as much as a concrete question. Feeling better, could be, I don't really want to be in medication. I don't really want to be here. I'll say more about that. Okay, so the patients were helped to resolve medication difficulties and strengthen their commitment to the medical regime. This is the focus of the intervention. So the overriding issue underneath it all is to what extent these issues have to do with more basic issues of problem acceptance, which individual experiences change is wanted, and we looked at that as part of their response to these different areas of better or worse, or forgetful or carelessness. We use that as a kind of guiding framework to see where that fit in to those issues. The second issue is to whether they felt extent to which they felt they were ready to do some treatment, engage in that distressing experience of trying to improve their lives. So how did these scores on forgetfulness and adherence or feeling better or feeling worse, how did that connect to these two issues about patient ambivalence and readiness to change? And as we said earlier, the underlying issue of those two conflicting issues is ambivalence. And so patients will express their ambivalence through manifested in different ways to those two different items on forgetfulness, carelessness, and also express ambivalence toward wanting to feeling better or feeling worse. So these issues get revolved around these two areas of acceptance and pre-problem acceptance, and overriding issue, to what extent this has to do with ambivalence. Okay, so the first issue has to do with how do we assess and understanding influences on adherence. That's the first issue we raised, is how do we assess this? We take it into two phases. Patients came into the study and we fill out the forms. Okay. So I've got some slides here I want to show you. Okay. As you can see here, majority of patients either were purposeful, not 48%, you see, fit into this category here. And only a small percent of the patients really have problems in terms of some of the physical manifestations. So we have most of the people fitting into this problem here in that purposeful adherence. It's very interesting because it means that there's some thoughts to wanting to take the medication. And this is just not organized or relevant to what I'm doing. Now, this is an issue, but it's not as important as these two issues around feeling better or feeling worse. Or this is the last one, which is the last thing. A person feels unintentional to have both this and this together. That's called the double whammy kind of thing. And we're experiencing both of those processes. So we focus a lot on this area here. Okay. Okay, so we looked at this issue here and what the scores were on these different measures here, and I'll say a little more as I go on. So what were the factors influencing problem acceptance? And that was the underlying issue. If we get the score, we want to find out what those scores really mean, and I'll say. So there's a lot of questions around people's misperceptions, understandings, and how it relates to medication, the fears of unintended consequences, the doubts of whether change is within reach, the negative relationship expectations, previous negative experiences, lack of information about the medication, rapport damaging interventions. That means there's a lot of discrepancy between the practitioner regarding the medication. And this overlaps with treatment acceptance. So the patient fills out this form and we think of it in this context. What that factors are, how did that influence their thinking about carelessness or purposefulness about taking medication? Feeling better or feeling worse, or I'm not really involved with the medication. Mainly around the purposefulness. That was a major issue here. So you close your eyes and you say to yourself, we got this person coming in with problems acceptance about the medication. He's not sure he really wants the medication, really feels he needs the medication. Okay. And so he's reporting back that I have problems of purposeful adherence. I have problems with that. And so the question comes up, how can we change that? How can we change that the medication becomes important for him? And why is it important? How does it make a difference? And so the person expresses it through these different dimensions on the questionnaire, but then we have to translate that as what do we do about it? How do we engage them around this aspect? And so I think in my mind, when a patient comes in and says, I don't feel better about taking this medication, or I don't feel good about it, or I'd like to not take it at all, I think, well, is the medication important to him? How is it important to him? And so we wonder about that as a factor in terms of their scores on the MAQ. Okay, so these are the strategies we use. So a person fills out the form, okay, and then we begin to say, well, what does that mean when you score this particular, you say you don't really want to continue with the medication, or you feel that when you take the medication, you're feeling worse about it, or life is not as good, or I'm feeling problems with it. So I'm saying, well, what does that got to do with their past medication experiences? And often they'll tell you, my doctor didn't seem to care when I took the medication or not. And so there's something about exploring these answers on these different questionnaires, on these different items that may be related to not caring. And then another question has to come with side effects. Okay, so people have had a very negative experience with dealing with side effects. And so if they're scoring a purposeful adherence and they're feeling worse about it, what's it got to do with? And they might tell you, in the past, I had side effects and I couldn't get help with it. I couldn't talk about it. I couldn't deal with it. So that's a second issue. And the third issue has to be is how can I use this information to strengthen adherence? So what worked for you in the past? What was better? And so I use the information to try to strengthen or keep their awareness of needing or being involved and so on. And so we wonder how all these views manifest in taking the medication. We monitor people throughout treatment. Is that some people, the minute they have side effects, they're going to drop out. So we really got to engage with them about people that are having side effects, because that's a major factor for dropping out. Another factor has to do with their day-to-day living situation. It's overwhelming for them. And you want to know how that affects them. So we try to elicit to them as a motivational approach the importance of the expectation in addressing the problems without judgment and interpretations. This is motivational interviewing 1. Acceptance, understanding, and non-judgmentalness. And that's a motivational interview. And then we began to look at trying to see what is the pattern here? Why is this person not taking medication? And all these issues we get come together gets incorporated in a medication plan. You'll see that when Mary and I role play at the end, how we incorporate issues into a medication plan. So the person's coming in getting medication, but what they're getting in the first interview is, what's the problem? What's going to happen with me once I take the medication? What's going to be like? And we looked at their past history and we see they've had 2 issues. Either they don't take it when they feel better, they don't take it when they feel worse, or they've had a history of carelessness and forgetfulness. So all these issues get weighed into this process here of trying to explore what these responses are. And we'll use MI as the intervention component to all these strategies. Okay, so at the end of the first intervention, in terms of the adherence plan of developing, we say, okay, so you're ready to talk about developing a plan. And also do what we call affirmations, strengthen their commitments, and all these techniques. We really can't explain all of it right now because it would be another study or another presentation. Is open-ended questions, reflective listening, affirming, and summarizing. We call this the ORs. Is basically use these techniques throughout. And this is not a presentation that's going to teach you motivational interviewing. The purpose of this presentation is how we incorporate this into adherence plan. Okay, so we just finished the intervention and the adherence about what it may be like in terms of assessing an adherence plan, okay, and looking, analyzing, understanding, and what the issues are, and so that we develop an idea that this person has adherence problems, will have adherence problems, and what we can do about that. Now, remind you, this is not done over 5 sessions. This is all being done at baseline when they come in. So, and they're not for long periods of time. Otherwise, they do a lot of different things, but we have a preparatory session around assessing and understanding adherence, and we have phase 2, which is developing an implementation adherence plan. This is all done within a intake evaluation. Anyhow, so we do this for a few minutes of doing an understanding, identifying, and then we do what we call intervention, developing intervention plan for every person that comes in. Okay, so we think about there, we get an intervention plan, we look at what those issues could be. And a lot of it has to do with their low self-efficacy. I can't take medications 10 times a week and all that stuff. It's too much for me. I don't like it. It's a problem. I got other things to do, and I don't feel I can handle it. It's too much somewhere. And that's very common, particularly with people with alcohol and drug problems that feel overwhelmed with a lot of different issues. The other issue is, this a mandated program? So the person's not here because they want to be here, or has had negative experiences with other physicians or other problems. And many people have had terrible, terrible situations with negative perceptions with doctors and so on. And they come in with very negative expectations. Nobody's going to care about me. I take side effects. I'm just a guinea pig, whatever they be. And so they have negative expectations. Second thing comes up is they've had experiences with practitioners who are pressuring them and giving them advice and telling them what to do and confronting them. And also sometimes being what I would call MI inconsistent interventions, which is stigmatizing people, shaming people, discounting people. That's been an issue, particularly in the alcohol and drug field, is they had a long history of damaging interventions. Other factors to consider is lifestyle factors, very busy lives, overwhelmed childcare, and so on, financial issues. And so there also has to be some belief that that medication will improve their lives. Is this the medication that's suitable? And is it working for you? So if the medication is not working, of course, that's a concern. So it's a legitimate concern. And we may want to change it. Doesn't mean that the medication is perfect. So we recognize that not all medications are useful, and some of them may not be useful. So we have to give the person's thoughts and thoughts about it, and ability to make their own decisions about it, whether this is really suitable, and talk about it with them openly and be transparent about it. There are other social cultural barriers, the Tuskegee experiment, where people feel used and exploited and so on. People have ideological commitments. The medication is a crutch, and they got to stand on their own, and so on and so forth. Those happen all the time. Although, if it's not as probably over expanded more than it is. I think people take it more literally than they need to be, because sometimes people are much more open to really discussing ideological commitments. Stigma associated with taking medication. And then the last is cognitive impairment. People that have cognitive deficiencies might have difficulty understanding and communicating. And so one has to slow down the intervention or use more direction or speak slower so that there is some handling around cognitive impairment. This has to do with people that have dual diagnostic. It's been a big issue in that population, who have difficulties conceptualizing what's going on. Okay, so we have this problem now, people coming in, and basically they not feel competent, or confident about the medication and so on. And so we want to look at them, helping them to feel more confident about the medication we'll be doing. Because we think that if a person's not comfortable about the medication and understanding of it, then they're not going to take it. So we have to say what really matters to them about how important is this medication going to be for you to produce behavior change. Underneath that whole issue is the person's choice. In other words, this is not something we impose upon people, but we explore with them if there's an options and so on about improving their confidence and the importance, but understanding that it may not be always appropriate for some people. Some people really should not be taking the medication. It's not helping them, or they feel so unhappy with it. So the option of choice is very much there all the time, proposing total autonomy. And we recognize the importance of empowering the patient's population. And that's not been the history. Most time in medications trials, get them take the medication. They got to take the medication, and they can make people better. It doesn't work that way. People have to feel some kind of commitment and ownership and so on. And that's what we try to do, help them to explore that process. And sometimes process works in favor of taking the medication. And sometimes the process works against taking the medication. And that's part of the issues here in motivational interviewing. Motivational interviewing does not impose any pressures on people. It allows people to make choices and so on. And something we work with people in a collaborative way, and being with them and sharing with them, as that we are there as facilitators, and not some kind of superior people or experts to tell them what to do. It's collaborative approach. I'm telling you my experience with that population, in this population, which was mostly with alcohol and drug use population, was very positive, because people didn't feel that the medication was something they were imposed upon them. It was something they agreed to or wanted to do, or felt that it was something that could be benefiting for them in terms of their change process. Okay, this is the sequence of strategies. So you just got an adherence plan, you just agreed to some issue that you need to work on. And then what I do is talk about slowing down the process. slowing down the process. Allow the individual to contemplate, to think about, to talk about it before actually stopping or even starting the midst. So there's no pressure right now. You got to start right now and get going, but let's just talk about it. Where things are, where are you at? It's called meeting the person where they're at. See where they are. So with the person's identified something and they think they may need to work on, what are you going to do about it? Well, I don't want to do anything about it. Okay, that's one option. What are the other options here? So we've just got some kind of idea of what you need to work on, but there's agreement to a plan. But whether they're going to implement the plan is the next question, is what are we going to do? And we look at then is that how this is going to work for you from the MIQ framework. What do you think will work for you? So you're not taking the medication, or you don't feel you can take the medication, okay? And so but you feel you need to take the medication, but you feel ambivalent about it, you're not sure. So let's see, what do you want to do about this process? Get these ideas, what do you think about it? Getting their input, getting their thoughts about it. And for them, it's very refreshing because nobody ever asked them if medication you got to take and so on. But I say, no, it's really something you need to consider if that's something you feel has been helpful to you. If you don't feel the medication is not helpful, that's a different issue. But sometimes it's worthwhile, at least doing it on a trial basis. So one time, person will say, I'll try it for 6 weeks and so on. I say, okay, that's one approach. Or maybe try it for 3 weeks. So what's going to be meaningful to them? That's going to help them stay with the medication and move them toward a way that's going to facilitate behavior change. One of the things we do here is that we try to offer people that there's not one approach to solving medication issues. We offer them what we call a menu of options. So we say, what do you think you want to do? And if some of them, they can't think of things, we might say, okay, so people that start the medication can benefit maybe by deciding after 3 or 4 weeks that this is something they really want to continue, that's one option. One option is to start and just use it for a limited period of time. Or some of the options are maybe you need to talk with your spouse about it before you begin taking the medication. So we look at different options, and that's very refreshing because then they feel that there's nobody forcing them to do it. And you know yourself, the doctor forces you to take a medication or demands the medication for you. It's the biggest turnoff because now you feel it's for him, he wants it, and not where you want to go. So what's most appropriate for the needs, preference, and that's a motivational. It's not a long-term involvement, but what do you think is going to work for you? What's best for you? Okay, and then we try to get their perspective. What I just said, what do you think? How does that affect you? And then I use things like reflective listening to say, maybe you're confused by what I'm saying, or maybe you don't agree with what I'm saying. And so I try to get them to take some ownership for disagreeing or having get their perspective. It's always a two-phase process, interactional completely. As Mary said earlier, it's a state and not a trait. They have to figure out what's best for them. And then sometimes we may decide to break down the long-term adherence goals into more manageable goals, like let's try the medication on a trial basis. Or don't try it at all and just wait and see if you can get better without the medication. That's an option too. So whatever is going to work for the client, we go with them and try to see with the idea of trying to, what they call a double thought reflection with a twist. Well, you tried that before, but it didn't work. So they made what they wanted to do. I didn't want to take any medicine ever. And you say, well, you did that before, but what happened? Didn't seem to work. So we do what we call double-sided reflection, but with a twist. Again, the motivational interviewing techniques, open-ended questioning, reflective listening, affirming are used throughout. And we teach this with our students to learn how to use ORs to achieve and sustain. So whatever you're doing, you can't go too wrong if you use those techniques. Listening, open-ended questioning, affirming, and summarizing. Those aspects are generic to this approach. The people we train in medication adherence are not very seasoned workers. Usually they're nurses or general practitioners or people that are just healthcare providers. They're not extremely knowledgeable about MI, but they know enough not to do what I think MI inconsistent approaches are. They learn these techniques basically in a kind of generic way. So that's been my experience in terms of this process of change, of working with people and training people. Okay, now I'm going to talk about particular categories. So we have the person here that says no on all the items on the MAQ. He, she, they have no problems with MA, with medication adherence. It doesn't mean they won't have problems with medication adherence. And it doesn't mean that it's all accurate. But what we try to do is what we call reinforce what they've been doing. So what's worked for you? Tell me, you've been successful. What was good for you? And if it worked, this worked for you, keep doing it. Seems to be you're ready to stick with the plan. So we try to figure out what they did that was working before to reinforce it, confirm it, and assert it as and prize them for it and commend them for it. And then at the same time, review the benefits of the medication. So it's not that because they haven't got adherent problems, but we just try to what they call build or strengthen the motivation and to do that. And I think that's been very useful to people and who don't seem to have particular problems with medication, but may have a problem. For example, things happen differently. The person's now traveling more or different dosages and so on. So we try to say, in certain situations where you took the medication before, this is a different situation. How it's going to be different now that you're traveling on business trips. Can you bring the medication with you? How are you going to handle it? Or you took one pill a day, and that was great, but now you're taking 2 pills a day, twice a day. How's that going to work? So then we try to build in strategies to address the issues particularly related to this medication. Okay, then we have people that have problems with forgetfulness and carelessness. Okay, so the answer yes to item 1 or item 2. And so we again reinforce commitment. It's great you filled out the form and so on and so forth. Again, we asked them about strategies that have been helpful in the past and so on. And then for those people, very often the strategies have to do with what they did before, which is calendars, reminders, support of others. We record that in the routine so that we recognize that's the problem they've had. And then what we do is try to incorporate things that they did in the past and maybe add a few other things that we've done that seem to work. So these people are not having problems with purposeful adherence around getting better or getting worse, but having problems at just doing the medication. Now we have the people who are saying they have issues around feeling better. In other words, particularly around people that come in and take the medication for a while, they get a little better and they feel better. They probably should stay with it because this particular medication, varenicline, you should be on it for 6 weeks at least. And people are saying, 2 weeks is enough for me. I don't want to be bothered with this stuff, and so on. So we wonder about how the medication, how that's going to affect them in terms of, how keeping the medication, taking it, how it's going to sustain their improvement. And so that we wonder about how this is going to continue on. It seemed to work now for you. Is this not taking the medication? Is that's going to continue to sustain your improvement? And we don't tell them that. They express their ambivalence about it. We'll reflect back the ambivalence and assert the ambivalence. And then they reflect back to us and say, it may not be a good idea. I can regress. I can get worse. So they tell you, and we react to it, respond to it. So we ask these questions to facilitate some ambivalence about the process to it, because very often people can't experience ambivalence. They have to experience the ambivalence. They're too frightened about it. They don't want to deal with it. So they use other things called denial or withdrawal and so on. But our job then is to help bring out this ambivalence so they can deal with it and deal with the issues are. At certain times, we might offer some information that I just said is that with permission. Don't ask information without permission because they don't own the information. They only own it if you ask permission. And you say, in this medication, it usually works better if you take it for a longer period of time. Using the example of finishing with the antibiotics. People should be taking antibiotics for 10 days, and they often feel better in 2 days. But that's not going to work if they stop taking it before the 10 days are up. So we use that example often. This other medication we do. The other idea we use, the other, I guess, metaphor is the insurance. You want to be sure it's working. You want to ensure, like you do with COVID or with the vaccination, you want to take the booster shot. It's an insurance to ensure positive results. That's another metaphor you could use. Having the extra shot and continue on is a way to continue the positive results. Again, I'm repeating, slow down the process, contemplate feelings, get them to, it's better if they have the process can slow down and not force a decision, because usually take better action with ambivalence over time. So in many ways, we'll end the interview with saying, okay, we talked about the issues that we haven't come up with an adherence plan, but let's come and talk about it again. And these are only 5 minutes. And usually they leave the session, they come back, they talk to their wife, they talk to their friends, and they say, I'm ready to make a decision right now. Maybe I just stay with it. This may be premature. So that allowing them not decide is as important as deciding. And these are all very, I guess, challenging issues, because in the medical field, usually it's get it done, do the work, don't ask questions. And that doesn't work. And I've done a lot of training with physicians who basically have generated a great deal of understanding about that, about slowing down the process and accepting ambivalence. Ambivalence doesn't mean, often a person says they don't want the medication. Usually that no is not agreeing with the approach, but it means underneath it all their ambivalence. So if they don't agree with it and so on, behind that is something I'm not sure that I really do feel that way, but they can't express it. But if you accept it and allow them without judging it, it allows it to come out, become more meaningful if it comes out from them in their process. Feeling worse. We have to pay attention to side effects. That's a major reason people stop taking the medication. The problem with the side effects is that it has to be managed and dealt with. And the person that comes in, takes the medication, doesn't know about side effects, is not prepared to deal with, is going to drop out early because he feels this is a waste of his time or her time or their time. And so that acknowledging side effects is very important to have a discussion around that. Because often we can give dose reductions or take some medications to reduce the side effects. But if you don't hear about it, you're not going to be able to deal with it. And that often talking about side effects gives you as a practitioner a greater, I guess, confidence and more trust, because you're talking about it openly and talking about it transparently. And it does increase rapport. So let me tell you about this medication. And you've had some negative things, but this medication does have side effects. Let's talk about it. What's going to do? How are you going to deal with it? And that the other process is acknowledging and ask about how to ameliorate and get them involved in that decision making. And often it involves dose reductions. But often what happens, you never get the dose reductions because the person doesn't come back. They stop taking the medication, you don't see them again. So the other aspect is to communicate, you're listening to them, I'm hearing you. During this period, I'll work closely to help you with side effects. So they know that if it does come up and you may be having side effects, somebody's there to be with you, to share with you, and so on. Waiting options. Person begins to talk about, I don't really think I'm going to continue with the medication. My life is busy. I'm feeling better already. And so that's an issue that comes up. Well, the medication is not for me. I'm much more independent. So we have to go back to square one with them, is going back to the assessment is why are you taking this medication? Or what did it help you? And what's the options? And is the only option to stop it right now, or something we should be thinking about a little more before you make a final decision? So you try to slow the process down. Many ways, I'll explore the ambivalence if it comes up and see if there are other options to modify the plan. That maybe they should give it another 2 weeks, or maybe they need to reduce the dosage, or maybe they need to have more support in taking the medication. So there's other options to do rather than just stopping. The last is medication is a crutch. That comes up all the time. It does mean people don't like being on their medication properly, and that's something we need to talk about and see whether it is a crutch. If some medications, you really need to take it regularly, and other patients, medication you don't. But you really want to know what the process is going to be in terms of if they stop taking the medication, and that what's going to happen, and what are things they could do rather than just stopping the medication to deal with this process. And often they say to you that people around me are talking this way, and I'm uncomfortable about it, and people are making fun of me, whatever that is. You can help them deal with the situation more directly rather than just dropping out or not stopping the medication. So review the situations. How do you handle that? What are your options and so on? And then the information you may be sharing is that for some medications, they need to be on it regularly, and the medication for diabetes, for example, is an important component. So then we get down to the bottom line. And there are people that are going to come in and they're going to stop taking the medication, and the risk, because it's not helping, consider the following strategies. Okay. So we always normalize it, which is very important for non-judgmental, non-interpretation. Look, this happens. Person already feels better. You listen, somebody's listening to them, is not reacting, not acting defensively. Look, this is going to happen. People stop feeling the medication. Okay, so that you don't really feel. Okay, so what are the concerns right now about stopping? The person may say, I'm not getting immediate benefit. And I say, that may be so. It's probably true. I may not get it. It may take a while before the impact. And that's something to share and join with them in that process. But you're not opposing them. You're dancing with them. You're sharing with them and so on. And it's going alongside of them. And rather than fighting them, acting defensively and arguing with them, is to say that in many cases, this may be the natural response to taking the medication, listening to them, and then getting back responses. Okay, so how does that make you feel? What do you want to do now about it? Okay. And so you don't seem to understand or agree with me or something like that. And you can relate that to them. And then the other thing is, rather than just stopping, are there things you can do to improve the situation right now, other than stopping completely? And then that's an option they have to decide. There are things they might want to do. Let me talk to my wife about it. Let me think about it more. Let me read up about it. Let me think about it some more and come back and discuss it again. And so sometimes involving family members or friends help with the plan. Get some good feedback from the spouses or the husband or the friends, so on. It can be very important. And then the last part is evoking affirming. Anything the person says to you that's positive and moving in the right direction, you want to affirm. So you keep your ear open all the process, and things are happening that you really feel make a difference in terms of where the person's heading, understanding, appreciating, making decisions. That should be affirmed, whatever the person does, just for being themselves and trying to improve their situation. That means you're with them. You're with them in the same situation, meeting them where they're at and joining them where they're at, and recognizing they're trying to do what matters. I said that earlier, doing what matters. Asking what matters to them and doing what matters, because it's for them to decide upon, not for you. They have to decide for themselves what's best for them. I know this sounds, a little bit too much, but in terms of working medication, a lot of the old responses to MI, bad, inconsistent MI come up about pressuring people, demanding advice giving, too much information, rather than trying to reflect with them what they're experiencing. Okay, the last part of it, summing up your conversation with the patient. And I say this with great humility and humbleness, that you've tried to avoid patients pressuring patients. And I've worked with a lot of nursing and medical staff who knee-jerk reaction, get anxious, the person's not taking the medication, and they feel they have to communicate to them what's going to happen and start giving them information. I can train people, and 1 minute, next minute I hear them yelling at people or demanding, you can see these are not just intellectual changes. You have to incorporate this in your personality about giving people a sense of their own autonomy. It's something that it doesn't come naturally. Most of us want people to listen to them and do what we want them to do. It's very hard to give up that control. So we apathetically reflect misgivings, and I call this giving a non-perfectionist message. You know, this happens every much. People feel this way. It's not uncertain. You may continue feeling this way. And it allows them to say that life is not so perfect and not so certain. And there's no sense of permanence of life. And there's no consistency, no reliability. And giving them that message says to them, it's okay. You can feel this way and we can accept it, and so on. In many ways, this what brings them back to you and say, you know, maybe what you said earlier, I'm thinking more about it. Some of these things I could learn more. So it does offering them almost a paradoxical effect. It's like joining with them, coming alongside of them, gives an opportunity to rethink what they're feeling and not act defensively or reactively. Last two other things. One is often the person who I feel needs the medication, is benefiting from the medication, has done well. I'll say, and right now you're saying no, but I do leave the opening to let's revisit it again. And usually people agree to it. So you plant the seed. So no is get out and so on, but listen, no is for now. Things could change tomorrow. Are you ready to keep talking about it? Come back in a couple of weeks and talk about it again, to revisit the situation. I've had many people come back and say, you know, I tried not using the medication. I didn't do well, but you know, I wanted to really consider it this time. It may take 2 or 3 visits, or 2 or 3 interventions, or 2 or 3 times for them to temporarily come back and ask help, other help. Again, the individual struggling with adverse situations may be better prepared to take action over time. Remember that contemplation, slowing down, giving them some autonomy, owing them, listening concerns, providing some information, and eliciting their responses to information, all go a long ways in terms of facilitating a medication adherence model. Okay, so what do we find out? Going back to advanced study. And this is not beating my own horn. I'm saying there's a lot of research issues, methodological issues. I'm just telling you what my experience has been to give you some sense of it and what happened in this particular study. So we knew that conventional strategies, just giving them calendars, alarms, and all that, reminders, really is not going to help, because most of them have what they call motivational care responsibility for purposeful adherence. You know, either they felt better about changing or they felt worse about changing. They felt they needed the medication. But those 2 issues were much more predominant than the conventional issues around, you know, forgetting and carelessness. So using that approach over here is not going to do very much, I think, for the medication adherence. A second issue that it did was it helped with practitioners to keep them aware of medication issues. So rather than spend time going to therapy and saying, well, what about the issues you first came in the study? They allowed them to focus particularly on adherence, which is different than focusing on, quote, therapy or drinking reductions and so on. It became a special area. We spent some time in the beginning, we call the preparation phase of how you deal with medication. So it was a separate component of the study, even though people got, you know, support for AA and went to other programs and so forth. We basically used this as a separate approach. And the patients gave us very high satisfaction ratings, very high. They thought this was great. And then in the study itself, we looked at the actual medication adherence rate. It was over 90%. Didn't matter whether they were adherent or not adherent. They all scored above 90%, which is meant that even the people that considered adherent got an intervention and got a medication adherent intervention. Even those that everybody got some kind of adherence plan, and we followed them throughout the study. So it seemed to have a benefit. I'm not saying the research is not, we didn't do a real design of this process, but we incorporated this into the Adherent study. It was very effective for us. So I'm a great believer in the approach. I'm a great believer in MI, and I think MI has a great value integrating it. But the problem with most MI, it's an add-on. You have to figure out how you can integrate this. And you have to know something about medication issues. You just can't do MI without knowing what the medication issues are. So that's one of the take-home messages, knowing about medication management, what they are, using MI, and then using MAQ, which is a very valuable, I think, instrument in terms of integrating. Conclusions. Working on confidence, importance is very important. Keep that in mind. Is this going to help somebody feel more important about the medication, need for the medication? Close your eyes. Is this going to help people feel more confident? So we use that as guiding principles, importance and confidence, what we do. You can't go too wrong with MI if you're thinking that way all the time. Integration of MAQ into MM raised practice awareness of medication adherence and provided the requisites and skills to resolve medication adherence and facilitate behavior change. And then ongoing use of motivational interviewing. Again, the people in this study were not highly trained MI people, but they knew enough about some of the basic principles of MI spirit and ORS to use it, and not even knowing what it was when they used it much more in terms of day-to-day practice. I want to thank Lisa Fushito and Stephanie O'Malley. They were both work with us on this manual and developing. And what I want to do in the next 10, 15 minutes before questions and answers, I want to do a role play with Mary about those two strategies. One strategy being with a person who feels worse, and then another strategy dealing with a person who feels better. And I'll be the practitioner with Mary in the first case, and then she'll be the practitioner with me in the second case. And then after that, we'll have a Q&A response. Okay, everybody? I know I covered a lot. I think what you'll do is once you see the intervention that I do with Mary, you'll think about it, and let's use some of the Q&A time to see how this works, how this really works in process. And I know a lot of MI people in the audience, so be nice to us. This is a risky venture. You know, we're always out there, and we didn't tape this, we didn't videotape it.
It's not scripted.
This is unscripted and so on, but we trust you. You're going to be understanding and kind to us and so on. But we'll do our best. Okay, let me get my little script out. I got some notes there. So Mary, welcome. How are you doing today?
I'm doing all right. Good seeing you.
So I want to talk to you. In your adherence questionnaire, you mentioned something about you stop taking medications when you feel worse. Can you tell me a little bit about that? What that really means to you? What's been the process?
Yeah. So, I've had this experience of being on all these new antidepressants. I'm trying to treat my depression here, and I'm just thinking, particularly one experience I had with an SSRI, Lexapro. I went on it, and I noticed these really, these side effects that just made me really tired and groggy and numb. I couldn't think straight. I was always very tired. I couldn't get up in the morning. And it was really frustrating, and it almost made me feel more depressed, and I've been so many years of trial and error with all these medications, and I keep trying a new one, and this particular one,
So you've had a lot of terrible side effects.
Yeah, I had a lot of side effects. It's really frustrating.
And what do you do when you have side effects? What's your response?
To be honest, I kind of just stopped taking the medication.
Yeah, that's it. Just stop it cold, right? Okay.
Yeah.
That's been one of your ways of dealing with it. Just stopping the medication cold. What happens then once you stop totally?
Well, then my depression, I know I'm not treating my depression. It's only, continuing on, and I'm sure there's risks to it, but the thought of having to go to my doctor again and telling him about these side effect issues, with these doctors today, I get 15 minutes with him, and it just feels like he's in a rush and he doesn't really want to listen. He didn't really give me a heads up that I was going to experience this kind of side effect, so I wasn't even sure if it was the medication. I had to do all this information on my own. I had to research it on my own, and it just made me feel less
No,
trust in my doctor.
it's really very, very frustrating. You having these side effects and so on. This is very not unusual to happen. You're having side effects and you want to talk to somebody, you want to, say what they are and how they're affecting you, and you get no response. And your reaction is to say, forget it. I just won't take it. But it sounds to me that you've made the decision on your own to not talk to the doctor based on your previous experiences.
Yeah, that's sort of the way I've gone, is just sort of avoiding the problem and I'm not talking to the doctor, especially if I feel like I don't feel like he's not working with me, but working against me, sort of not willing to listen to me, and certainly didn't prepare me for what I could start feeling when I started the medication. It was sort of just take it, see
Have a
me.
lot of negative feelings about transparency, openness, integration. Have you had other experiences where this hasn't happened?
Yeah, I've had like other moments of being maybe on more short-term maybe antibiotics or just any kind of short-term medication prescription. I've had, when I feel prepared and the doctor has sort of given me a run through of what to expect when I take the medication. There's a sense that they're working with me and they want to listen. They care enough to hear if the medication isn't going well, and they make the time.
So it's very important to you that somebody listens to you and takes you seriously and really is ready to engage with you, the process. And this hasn't happened with this particular doctor itself. Okay.
That's right.
Okay. So let me talk to you a couple of ideas about it, summarize what I'm at. So you've had this issue about the side effects. It's really affected your medication. It's hurt you. You get depressed again. You can't talk to your doctor about it because he doesn't seem to care. At least you feel he doesn't care. But you don't even want to talk to him because you feel his attitude precedes that approach. Okay, that's where you're at right now. So what do you think you should do? What do you think what are some ideas you think you should do about it?
I'm kind of torn. On one hand, I know that, the right thing maybe is to go see the doctor, but I dread talking to him about it. I'm tempted to just go back to not taking it. I'm not quite sure what my options are other than those.
Well, you always have options. One option is to keep doing what you're doing, but that doesn't seem to work for you. It ends up not taking the medication. Another option may be to perhaps talk to him this time and confront him what he's not doing. A third is to looking for another doctor. A fourth is just to think about it and not do anything. Just maybe come back and talk to me again. I think I can't decide for you what you need to do, but it sounds to me that you have this dilemma, and I praise you for accepting that dilemma and be able to talk about it. But the second phase is what you want to do to make it different for you, what's important to you, and what you think is going to make you feel more confident about the process.
Yeah, I think, being able to talk to you just now about sort of weighing my options here has actually really helped me sort of see more clear what my issues are. And being able to talk to you has been really enlightening, sort of, and figuring out where I can go from here.
So talking to me is somehow that's what you feel comfortable about, and that might be at least a first step to doing something else, but at least to talk to me about it and feel comfortable with me. And that could mobilize you conceivably to take some future action steps.
Right. And not to feel pressured to make a decision in the moment, and having the chance to think about it and think about what would I really want, then I can make the proper decision.
That seems very reasonable to me. Very reasonable. Okay. Okay. Now we're going to switch roles. I'm going to come to Mary and talk about my issues around medication, and this is going to be more from the Wernicke study. And Mary's going to interview me. Hi, Mary.
Hi, Ellen. How are you?
I'm good.
Thank you for coming in. So I know that response to the MIQ, you said that, you stopped taking medication when you're feeling better. Can you tell me a little bit more about your experiences so far with taking the medication?
Well, I take it, and this medication has helped me a lot. I'm not smoking anymore, and I'm drinking less. But I don't like the burden of having to deal with this every 3 hours and taking a medication. I'm ready to blow it off. I'm feeling okay right now, but I don't know. I can't continue. I'm not a good medication person. They got the wrong person for this process.
So Alan, it sounds like, first of all, that the medication has worked for you. In one sense, you've been on it for about 2 weeks. You've completely quit smoking and you've seen a reduction in your drinking. On the other hand, you're not really a fan of being on the medication in general. It's almost as if you feel like you're over medicating yourself, or you're relying on the medication as a crutch.
Yeah, that's about it. Most of my friends aren't taking medication, and and they're okay. I don't know why I have to take this medication. It's sort of undermining me. It's demeaning me to do that process.
It's important for you to feel reliant, and it's important that you do this independently.
Yeah, definitely. I work every day and I take care of my family and so on. And so why am I on this damn medication? I know I'm not drinking and not smoking, but I don't know. I'm ready not to continue this process.
I understand, and it sounds frustrating. You have a lot of responsibilities. The medication is demanding. You take it 3 times a day. It is part of this study. Alan, can you tell me a little bit why you began taking this medication and wanted to enroll in this study?
I've had a problem with drinking all my life. And so this is the first medication that's really had any benefit. And what's important is that I'm smoking too, and I have stopped smoking because of this meds. So it's really benefited me at least in the short run.
So the medication has made a huge difference in your life.
It has. That's why I'm sorry to give it up at this point. I'm just feeling frustrated.
So you've made great progress in this treatment so far, and at the same time, you're sort of questioning why do I need to continue on this medication if it's working? Why, it's sort of become an afterthought, almost bothersome now. It's been sort of maybe perhaps 2 weeks ago at the forefront, but now that you've seen success, it's sort of moved towards the side burner a little bit.
I'm looking for you for some advice. What do you think?
Yeah. Well, do you mind if I share some information with you about the study and let me know what your thoughts are?
Okay, sure.
So it's often that it takes, when we start taking medication, we sort of reach that threshold where we start to notice improvement in whatever we're treating with the medication, which is good. It means the medication is working and we're seeing the results we want to see. But something to note with this medication, similar to antibiotics, it is recommended that you stay for the full course to get the full benefits of the medication. Can you tell me what your thoughts are on what I just shared with you?
Well, if I'm going to keep this medication, I need some help. I'm pretty much, since COVID, I've been alone. I don't tell my wife about it. She doesn't know anything about it. I was thinking that we're about to take these pills, and she said, we just know what's going on. She knows I'm not drinking, and she's happy about it. But I'm pretty much alone on this process. I don't share any of this with anybody. And it's getting me down. I don't have any help around this. I must tell you that I'm not getting any help with this process. It's a burden on me, except what you've done for me right now has been helping in that response, but I don't get any help.
So having that social support system would be really motivating to you.
It would, at least if I could talk to my wife about it, and she might, she does other things, did you take a shower today? Do this, she does a lot of support to me, but not around this.
So it sounds like your wife in other areas of your life sort of gives you that extra external push to accomplish certain things. And now you're seeing that perhaps there's a connection between not having your wife involved is leading towards a waning in motivation with the medication.
Definitely, definitely. Yeah, that's a good point. I
So
agree.
can you tell me a little bit more about how your wife has helped you with motivating in certain behaviors in the past?
Well, she knows, about exercise, eating, a lot of stuff. But this one I've been too shy and too inhibited to talk to her about, is alcohol medication stuff.
Right. You don't feel comfortable
She
sharing with
knows I'm
her.
coming here. She doesn't know what I'm doing. She has no idea.
So Alan, it sounds like, you are conscious of the fact that your wife is supportive and provides you some motivation in other activities. At the same time, with involvement in the study, you haven't necessarily included in her for various reasons, for letting her know why you're in this study. I'm curious, can you think sort of what would be motivating to you to continue with the medication?
Well, having her involved would be an important element. Can you talk to her for me?
Well, first of all, Alan, I'm going to reiterate that this whole process is up to you, and it's up to your decision ultimately to partake in the medication and how you want to address it. I'm certainly here to provide support and guide you through this process.
See, well, I should talk to her about it. Well, I can use the help with that. I don't know how to do that.
So you want to, I think we can work together as a collaboration to consider ways that we can begin to talk to your wife about this process.
That would be the beginning step, because I'm not sure how to bring this up with her, discuss with her. I'm afraid she might just reject me, whatever it is.
Do you think that maybe before I see you next, you can spend some time thinking about how you may want to approach the subject with her? And then when you come back with me, we can brainstorm?
Yeah, I think that would be good.
Great, Alan. I think that sounds like you have a plan.
Okay, everybody. Thank you. Hope you withstood. So we have some time for some questions and answers. Questions about the role play. Be open with us. Let me know what you need to know, what you don't. Mary and I will do our best.
I think, Tiffany, if you don't mind relaying the questions that have appeared in the Q&A box, Alan and I will do our best to answer.
Yes, definitely. So we have some questions here in the Q&A box. We're going to get through as many as we can. So I'm going to go back to a question that was asked earlier in the evening. And if the question is, do you consider race and ethnicity when someone is anxious about taking medications? Can you speak to that a bit more? So for example, Black and Brown people have been historically abused by the American hospital and healthcare systems for centuries. How do you speak to this within MI and acknowledging that?
Very sensitively, totally understand the issue, knowing that they would see this in a very different way than the white person would see it, something that they may feel enforced. So MI is particularly important to give them a sense of ownership and understanding and sensitize ourselves to these issues with people of color. We've had a lot of experience. Most of the people of our training, we've done a lot of training in this area. A lot of people of color don't go into medication studies at all because they're distrustful, and they could benefit. Some of them could really benefit from the medication. But I think you've got to be very, very sensitive to this process. And having people of color work for you and join with you in the process and act as practitioners and serve those roles, I think does reduce some of that concerns. And we've done that. And I certainly think it's an important issue, especially with medication. And as we know, a lot of people are there because of different colors, or diverse people are excluded from medication. They don't get it, they don't read it, though they can benefit from it. So we have to be very sensitive to this process. Great question, important question. I think we continue working on it and continue sharing what's going on and learn by it and so on. And MI is very interested in this process to begin with.
And I just want to add, one of the key pillars here in MI is acceptance and absolute regard for the person. And, as I was speaking to earlier, sort of the old archaic way of approaching medication adherence, was blaming the patient and seeing it's one of the reasons it's undetected is it's like, well, that's the patient's issue. They need to figure that out on their own, and whatever issue it is, doesn't matter X, Y, or Z. What was been traditional is like, I'm not gonna neither here nor there for that. Whereas now with MI, we are, like I said, the sort of that belief system that we're coming in. This is a shared decision-making process, accepting where the person is at, understanding the legitimate concerns and hesitancies that do exist, not just for the individual, but in the larger system.
Thank you, Alan. Thank you, Mary. And following up with that question, another one of our attendees also did say, how do you respect one's religious background, yet encourage them to take medications which may be beneficial to their health, but against strong religious beliefs?
It's an issue. I think, first of all, as I said before, explore them where they're coming from, understanding where they're coming from, accepting where they're coming from and saying, this is an issue for you and so on. And explore some of the options. One is not that if they're bringing it up, they may have some ambivalence about it if they're coming. So where's the ambivalence? What's going to help them to feel that they can accept the medication, how it could be? And sometimes they may need to speak to their other people and say, look, it's an option that I need to, and talk to other people of similar persuasion and talk about whoever is going to be helpful to them. A significant further can be very helpful in that process. But the worst thing you can do is to try to turn them off and say, those feelings are not valid and so on and so forth. That's really not helpful. Helping them is to understanding where they're coming from and what they're ready to do, and joining with them and saying, listen, this is an issue for you and it's respected and so on. But disrespecting people and accepting people where they are go a long way. Again, we can't force anybody to do it, but if they have some ambivalence about it, we might be able to explore what they be. Maybe they can take medication for a short period of time. I don't know what the answers are right now. It depends on the person, but I think it's worth exploring and trying to engage with that process. I do appreciate it. I think it's an issue for all of us all the time, not just with medication, with any kind of approach with people. We have to begin where they are.
All right, thank you. This one is specifically about one of the role plays, and our participant says, I noticed that Dr. Zubin followed up with 3 questions back to back at the beginning of the session. In my counseling classes and training at Crisis Text Line, we were taught to avoid back-to-back questions to avoid making the client feel interrogated. How does this differ for motivational interviewing in regard to medication management?
MI hasn't got the ownership of terms like, not interrogate. I mean, those are issues that go beyond any kind of approach. People shouldn't feel interrogated. MI doesn't say they own it particularly. MI has adopted a lot of these very good techniques from good counseling and good person-centered approaches, incorporate these techniques. Carl Rogers, who in many ways influenced motivational people, began doing these techniques in the 1920s with 2 social workers, Virginia Robinson and Jesse Taft. So these approaches of reflective listening and not go back, 100 years. These are not owned by MI, but we've incorporated those techniques in the process. It's not different than other counseling approaches, and it doesn't get from person-centered approach by Carl Rogers. So we don't own those techniques. We adopt them, incorporate them, and maybe operationalize them a little bit better. But it's not a particular MI, model or strategy.
What was your impulse when you were challenged by the client not responding? Like, what did you do to resist the urge to solve the problem when that comes up?
Great question. Mary, you want to take it?
Yeah, certainly. So there's 2 issues in that question. So one, definitely stonewalling if client's not responsive. And the second issue is, how do you resist the urge for pushing your own agenda? So for the first one, when the client's not responding, this is where you kind of have to consider shifting focus and thinking and asking the client, perhaps they're not ready to discuss the issue at hand at that moment, accepting where they're at. What would be most helpful we're here meeting right now. What would be most helpful for you at this moment? And showing them, sort of asserting and emphasizing your role as somebody who's a collaborator and a guide through their own process of enhancing their motivation. And ultimately, you sort of have to accept where the client is at, and that even means accepting perhaps they're not ready to do something. In fact, with the role play with Alan, where I was the speaker, I didn't really make a decision. He sort of said, why don't you think about it and come back? So it's not necessarily the rush to sort of solve the problem in the moment, because when you are going to rush, when you are going to force that behavior change without the person verbalizing it themselves, making a plan themselves, it's less likely to happen. And that's also tied to persuasion. And as I mentioned earlier in my other slides, when we label and deem a client a lost cause, they have to hit rock bottom first. They're more likely to actualize those labels and see themselves not fulfilling the treatment goals if it's being imposed on them. And people are more, this is sort of the supportive hypothesis of MI, right? Like, people are more likely to undergo behavior change if they're the ones saying it, if they're the ones talking about it. So if I'm constantly telling you, you got to take this medication, you have to, it's not going to produce any successful behavioral change. By asking the person, what would it take for you to feel motivated to take the medication? What would it take to help remind you or to continue the success that you're seeing? Thereby, the person's eliciting their own original thoughts, or original ideas of how to take the medication. And this has been studied as well.
Yeah, I agree with the question. As much as we motivational people, basically, in the street, everybody talks. How do you help people? We ask a lot of questions and tell people what to do. That's basically the human approach. Anybody in the street, that's probably, they don't do motivational interviewing. That's been the normal approach. So my approach is very similar to that. I feel like I got to tell this person what to do, and I have to ask questions, but I know implicitly I have this visceral sense you can't do that. You got to stop. I got to be in touch with those feelings. Otherwise, I'll act them out. So my first response is get in touch with those feelings, realize what they're at, and then realize what you should be doing, what needs to be done, as from a more compassionate framework, loving kindness and concern. And that part of it comes out. So if you think of basically MI as loving kindness and concern, that mitigates those other feelings you have, which is telling people what to do.
All right, thank you. The next question, what would you do when a client is faced with potentially fatal consequences if they don't adhere with treatment within an MI context?
Asking permission. You don't tell people, and expressing your concerns. We're transparent, but you have to say to them, can I share with you my concerns? I have some thoughts about it. If he says, she says, they say no, then that's the answer. But most people say, okay. And you show them what, you give them the opportunity to listen to what it is. And the fact that you ask permission, which is key, if you don't do that, they're not going to own it. But they asked you for those, they agreed to listen to those concerns. So there's some ownership there. And sometimes they need to, live with live with what you told them and decide what they want to do, which may be to not come back or come back again. But you always give them the option of, if things change, you want to do it. I say temporarily, everything is a temporary thing, is to say, listen, right now you're feeling this way, and this is some of my concern. But if things change, you try to plant the seeds, because not all change happens at that moment. Change happens outside the sessions. In fact, more importantly than in the sessions. So I wouldn't take that as a final word.
I just also want to address, so I think the question was about also like a fatal consequence. Obviously, there are situations where MI may not be the most appropriate. However, that's not to neglect. We didn't really talk about sort of the meat of MI and the MI spirit and the specific skills, but I would say in that moment, perhaps more of the MI strategies aren't appropriate if we're talking about fatal consequences, but coming with the MI spirit, with collaboration, evoking compassion and acceptance.
Correct.
Thank you. Has this approach been used with vaccine resistance? Could it be effective?
Yes, there was NASW had one recently with COVID hesitancy. It's a special issue. I didn't want to spend time on it tonight because I think there are a lot of issues, political issues and ideological issues, and what's going on in this country. It really requires a special session related to COVID. I think it can be, and it has been, the ambivalence, the same issues occur, ambivalence, uncertainty, ownership, problem. We have these problems are transferable, but I would have to spend a lot of time with Mary to talk about. We did one about 2 years ago with our lab instructors around COVID hesitancy using MI. We did describe some of the issues and so on, but I'd have to have a special session devoted to that because those are special issues but the same issues are, the same techniques apply, same model applies, but you have to then talk about how it becomes operationalized. And often people don't do that enough. They talk about exploration, listening, and blah, 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 but it's really very different how it's used in an operational way, in a day-to-day way. So it's a good question, but I think we can not answer it fully right now.
There are other presentations that have been done on COVID vaccine and MI. It's worth looking at.
All right, so another question is, can you guys provide some suggestions for using MI with young people who are reluctant to start psychotropic meds and may not have had many or any positive experience with medication adherence to draw upon?
I would say we have to do a little more role induction to this process for people like that who are coming in. Spend more time nurturing them, getting information to them, understanding what their concerns are. Their issues may be different. They may have different concerns about the lack of information is a big issue. Some of the benefits and some of the costs. So I say you may have to slow down the process, watch your language, don't use jargon, and make it meaningful to them by adapting those techniques to that population. And we can role play that with you and show you, but I think you've got to adapt it to different populations, whether they're people of color or they're people, younger people, older people. The model stands for whatever. Problem acceptance, treatment acceptance, guidance, confidence, importance. Those are models that go across. But the trick of the process is to adapt it for the population we're working with.
I'm also thinking just in terms of a younger population, what specific strategies, maybe ones that are a little bit more interactive versus conceptual. Like, I know it's not really used anymore, but weighing pros and cons, like cost and benefit, the scaling question, you kind of picture how on a scale from 1 to 10, how ready are you to take this medication? They give you a number and have them verbalize why that particular number over a lower one, or what would it take to get to a higher one? So I'm thinking just in terms of specific strategies for younger people, more interactive ones that maybe make it more concrete. And then obviously psychoeducation and education would play a big role.
So let me say one thing to everybody about this. Motivational interviewing is great. It's not a formalistic. There's no formulas, prescriptions. There's listening skills as intervention, listening and responding appropriately. So we're saying that it's good across the populations. We've got to listen to who these people are, what they want, what's important to them. And those skills are essential for everybody working with. And from Alzheimer's people, with people, some of the same skills apply to that population as well. Just the way it's applied, it's a little different.
Another one of our guests is asking that this seems like a teachable approach within an organization. And Alan, you mentioned that practitioners in the advanced study didn't really know MI or know it well. How would you suggest training staff, or what would you suggest needs to be a minimum of what or who should be trained in using this approach in MI?
Great question. We have a model that we use. It's called experiential model, which we use it, we adapted. It's a hands-on doing approach. It's not lectures. It's like sitting in and saying, let's try this. How are you going to work with this? It's really it's working with people on a day-to-day level and finding out what's going to be helpful to them. And the motivational strategies gets discussed after you've tried it. So you'll practice, get a feel for it, understand it, and say, aha, this is working. How did this work? And the part of the MI principles gets discussed afterwards. So there's no lecture. The lectures or discussion about frameworks and concepts occur after. So people learn to practice by doing. And that's a very effective way of helping people of different educational levels, different skill levels by doing, because then you can use the practice, which is a very way of people getting a feel for the process. And that's very important. And people have been doing MI, not all are conceptual, like articulated, but they know that you don't yell at people, you don't argue with people, you listen to them. And these are basic MI skills. They may not have the conceptual model articulate what they are, like graduate students, but they learn what we call MI consistent, MI inconsistent. And they learn that process through doing and being with people. And we've done that. We've actually published something on it recently, what those skills are. And there are challenges for different populations to work with. That one challenge, for example, is what does it mean to be a helping person? How does the client experience you as a helpful person? That's a generic issue, whether you're working in a psychiatric hospital or you're working in a people aging. What does it mean? So that's something we train people in understanding what it is to be a helpful person. And that also report. I don't want to go into details about it, but we train people where they're at using this experiential model.
And the learning by doing is through role play and real play exercises and simulating encounters with clients.
I mean, Mary and I could have started to host this whole presentation to start with the role play, and then we'd have another session, but we can start with that and then work our way into what the issues are. But this is a webinar. It's not it's not a workshop.
In regards to the training and developing staff competencies, just in general, do you guys have a book or a number of books on MI specifically that you recommend? And I'm saying this with a grin on my face because I know you do.
Well, I hate to promote. I wrote a book with Bill Miller called Treating Addiction. We have a lot of MI stuff in that book. Bill and I and Lisa Forsyme wrote this book a couple of years ago in 2019. The MI book with Miller and Rolnick is always very useful. That's the third edition of Motivational Interviewing.
There are great sort of workbooks with MI workbook skills where you can, there's the literature, but then also working through exercises. And I'm happy what I'll do is compile sort of 3 or 4 good books to put on that handout link, including the COVID and the slides, of course. But I'm happy to include some books in there.
Also, there's videos around and tapes and podcasts. I mean, there's lots of stuff around. So just go on the website and look for motivationalinterviewing.org. You'll see a lot of material.
Before we wrap up here, so from one of our attendees here, they said this was a really, this was a productive webinar, and the role plays, and they have read some studies on brief motivational interviewing, where the estimate is approximately 15-minute interaction in a physician setting. So the question is, do you see an average time frame, including number of visits, that you find creates the most success within MI?
12 sessions, like the classic.
I've done work with screening and brief intervention, and I use motivational interviewing as part of it. MI is more of an add-on. It doesn't present therapy in itself. It's an add-on to what other people get. The screening and brief intervention has used MI. We have Mary wrote an article about that. So it depends on what you're doing. But I think with the medical management and MAQ, basically those sessions we did around adherence monitoring was very brief. It was be 5 to 10 minutes about their adherence and their adherence plan at the end of each session. They came for some counseling, but the adherence component was always built into that as part of an ongoing monitoring intervention tool. So you can do MI very briefly. I think it's a very adaptable approach. Mary, you want to say something? You had something?
No, I also just sort of want to give a caveat to the role plays, because I know during our role plays, other sort of issues came up with when Al and I played the patients. Like there were definitely some underlying issues that could have been addressed, but just to give a frame of reference, we were trying to really approach the medication issue. Obviously, in a more therapeutic setting, I might have discussed Alan's thoughts about being in the study more, but we were really focusing on how would you approach the medication issue, medication adherence?
Yeah, we don't want to confuse people. We worked on the study, particularly around medication adherence issues. There are a lot of things going on in this study around therapy, as Mary said, but we didn't deal with this in the medication issue with something very specific. And you can see we had a 90% compliance rate, which was really amazing for medication adherence.
All right. Thank you. Thank you, Alan. Thank you, Mary. And thank you, everybody who's joined
Thank
on
you,
and
everybody,
joined
for
it.
coming. We appreciate that.